Hi guys, and welcome to another episode of Emergent Leadership. I am fortunate enough to be with Dr. Victoria Reinhartz today from Manatee County, Florida, with their mobile healthcare program as a pharmacist. Dr. Reinhartz, thank you for being with me today.
Oh, thanks for having me. I'm a follower of your podcast, and I'm excited to have the pleasure to meet you today.
Thank you. I appreciate it. Well, I'm excited to talk to you because you serve a very different role in the industry for a very kind of innovative program. And I'm anxious to hear from you. I know our audience will be as well. So I want to start by learning a little bit more about you for those who don't know you. If you don't mind kind of helping us get to how you have a doctor in your name and are a pharmacist and working on a mobile integrated healthcare program in EMS. How do we get there?
Yeah, I know it is definitely unusual, probably within the world of mobile integrated health or community paramedicine. So a little bit of background about me. So I am a licensed pharmacist. I'm a licensed consultant pharmacist in the state of Florida. Not all states have the same licensure procedures to be a consultant pharmacist, but the intensity is a little bit different depending on the state that you're in. So I am a licensed consultant pharmacist in the state of Florida. I have been a pharmacist almost a decade now. Don't tell anybody. I guess I'm letting the secret out.
Yeah.
But I'm no longer considered a new practitioner or any of those things. And my background is a little bit diverse in the sense that, you know, I started as a pharmacy manager for Target back when Target was Target before it transitioned into CVS pharmacies. So I spent several years as a pharmacy manager for Target. I was promoted to a district resource for Target. So that gave me a lot of experience with, you know, evaluating outcomes of store performances, looking at profitability of pharmacies, looking at revenue sources, and being in charge of a lot of training initiatives within the Tampa Bay district in Florida here. And then I accepted the professorship about 5 years ago at LECOM School of Pharmacy. So that's LECOM is a little bit weird. It stands for Lake Eerie College of Osteopathic Medicine. And I am a faculty in the School of Pharmacy. So I'm full-time faculty, have been for several years, and I work within the Manatee County EMS under their Community Paramedicine program. And, you know, it was an interesting road to get from academia into EMS and community paramedicine. And, you know, that kind of started with a crazy idea and having an EMS chief local that was like, let's innovate, let's try a partnership that's really unique. And so, you know, that was back in 2015, 2016 that we were considering a unique partnership based on the needs of our community. So here I am. That's history. Yeah.
I love it. So that's interesting. So you actually started, you know, if you consider it this way, you started kind of your EMS career in the commercial side. So understanding, you mentioned a few things which I'd love to dive into, but managing a team and training and education. But you mentioned something that I know we don't talk about a whole lot as an industry, or maybe some people do and it's a small subset. Talking about the pharmacy and the processes and the revenue and that kind of business model side of the piece of the equation that we rely on every day in EMS, right? People taking the meds and being able to fill the meds and the prescriptions and being able to access that healthcare piece that a lot of times is forgotten in a community. So it's interesting that's where you started, and I'd love to dive further into that. Where did your passion for all this come from? Obviously, being a pharmacist, if you went through your PhD, I've got friends who've done it, and they say it's more just they're masochist before they knew it, I guess.
Yeah,
But
it's interesting. So I've always had a love for things medical, and I love pharmacy because every single one of our patients is like a puzzle, right? So, you know, if you take a drug, Brett, and I take a drug, we're going to have different reactions to it. It might work really well for you and might not work at all for me. And we find that with our underserved populations, our minority populations, our elderly populations, you know, these patients that really need our help the most, they are even more prone to the discrepancies, and they have access to care issues and a lack of health equity. And so all those elements around how medications work for them are much different. So the puzzle piece is what I love and what makes my brain grow. And that's why I'm probably an innovator and like big on long-term vision of team dynamics and revenue and profitability and operations, because I love a puzzle. So it ties into the role of why I love pharmacy, why mobile integrated health and paramedicine is a perfect avenue for me, because those patients need us to help figure out what's going to work for them, right? What works for them might not be what works for the other 90% of patients who aren't having issues with rehospitalization.
Right.
So I think it's a blend of all of those things, right? But for me, it's figuring out that puzzle is where my passion probably comes from. Yeah.
Sure. Well, and you know, obviously, you know, my part of my passion is learning people and understanding what makes people tick and why they do the things they do. And so I like to go deep and understand that. We're 5 minutes into this discussion. I'm like, tell me what makes your heart happy, right? Like, tell me what makes you tick. But I think it's you know, what a beautiful space to be in, that you're doing something you love, and you know, you're able to really be true to you in that. But I heard you say a few things. You're serving an underserved population, and that you understand kind of the different pieces of it. That puzzle piece is something that, you know, my experience, I spent some time in a system that did mobile healthcare, is, you know, very renowned for doing community paramedicine, also now nurse navigation, and a few other programs aimed at serving those populations better. And I know that every one of the programs across the country looks and feels different. And that's one of the challenges of mobile healthcare, is that what works in, you know, Manatee County, Florida may not work in Dallas, Texas, or Las Cruces, New Mexico, or wherever that is. So I'd love to learn a little bit more about you guys' program, and why is pharmacy a big piece of that in the region of the world that you're in, the population that you're serving?
Yeah, so in Manatee County, our program is structured based on community health assessments that were completed, and where, you know, the leaders in our community identified what our biggest needs are, right? And so we have 5 program categories. We have substance use disorder and mental health, diabetes, cardiovascular or respiratory diseases, falls, frequent falls, and then finally, if you have a patient that doesn't fall into any of those others, we have our high system utilizer group, right? So patients that are still calling 911 more than 3 times in 30 days. And so, you know, you get like your wound care patients, dialysis patients, we have a fair number of cirrhosis patients, cancer patients, those sorts of things that fall into that last category as well.
Sure.
So our program is a little bit more robust, probably from a medical side, in the sense that we have a lot of chronic disease. And so there has been a lot of training and development in the different chronic diseases. And of course, you manage those diseases with medications, right? A lot of behavioral, a lot of non-pharmacologic as well, but the medicines are a huge element. And we also know that, you know, medications and the ability to manage those chronic diseases contribute to the rehospitalizations, right? That's why patients are calling 911, ending up in the ER and going back to the hospital. A lot of the times, even up to half of the time, the medication is the problem. And so obviously, you know, my role is a little bit more robust probably within our program because it's so medical. But the key here is that, you know, yes, the medications are a big piece of it, right? And that knowledge and that the degree, right? The 8 years of schooling that I went to get the degree to be a pharmacist is a huge part of what I do on a day-to-day. But I think a lot of it is about, you know, you can tweak the need to any program because they are all going to look different, right? So, you know, there's a huge disease management and medication piece, an efficiency piece of the team, even within like a falls program, or even within a substance use disorder program, or whatever the focus and needs of each individual community are.
Sure. So I would love to learn more about the falls program, because I think it's something that's probably heavy on your mind. Just had shared with me before that that you're having some pretty exciting conversations at a bigger level about the great things that you guys are doing. And I'd love for you, if you're comfortable with it, to share a little bit about that program. And how does pharmacy fit into that equation? When I think falls, Dr. Reinhartz, I think of, animals and walkways and halls and who's co-inhabiting with these people. And I think of the chairs they're sitting in. They're all physical things that I think when you go in a lot of these programs, when they're doing a falls risk assessment, it isn't necessarily pharmacological review. That may be a piece of it, but I would love to know how that fits in that specific program.
Yeah, so there usually ends up being in almost every one of our falls patients something pharmacological that's coming into play here. So the process can get pretty complicated, but I'll kind of summarize some of my bigger elements to the approach that I take with our falls patients. So number one, there's a reason that they are falling, right? And the home safety assessment is probably the first and most critical piece, right? But there is a physical reason that they are falling down, right? So either there's some sort of neuropathy piece, there is a coordination piece, they might have underlying diseases like peripheral neuropathy, that might be causing their legs to be numb. They can't navigate as well because they've lost that feeling and sensation. They might have, something like Parkinson's disease. They might have even issues with their blood pressure bottoming out. Whatever it is, there's often a physiological reason that is contributing to those falls. Sure. Sometimes it's obvious, like there's a medication and the dose is too high and it's causing sedation. Mm-hmm. Or something. There's also the need for lab evaluation, right? So their electrolytes might be off because of the diuretic they're taking. And so it's causing their fluid electrolyte balance to go off and contributing to falls. We know that the way drugs work in the body for our elderly is significantly different than in younger populations. And so they're at a significant increased risk for drug toxicities. Mm-hmm. and in resulting accumulation of the drug in the body. And so we can help, combat that.
Sure. Well, it's just so interesting because I know, there's like a couple programs across the country that I know of, and it really is, when done right, driven by a need of the community and, what the predominant or prevalent disease processes are and community challenges are. It looks and feels different everywhere, but it sounds like, I'm convinced that there's probably a pharmacological, at least review for all of these patients, because I think one of the things that's missing, if I had to make an argument, and maybe this is a little bit of a teaser to what my podcasts are going to start looking like moving forward, if I had to make an argument for or against, or what I think the challenges in EMS are, I think one of the big challenges, I would simplify it to say technology and gaps in communication, or gaps in technology that cause gaps in communication. And one of the classic gaps in healthcare is Dr. A doesn't know what Dr. B is doing. And because we don't have, patient records in little, things in our wrists with all of our medical history, and we're not doing that. There's always this, hey, fax me this information from this doctor. And there's this disconnect in even just in active care plans for a patient between one physician and another. And a lot of that is rooted in technology. But I think some of the downstream effects are, to your point, people are taking medicines and there's contraindications of something that somebody else doesn't have any clue about. Until you get into their home and pull out all their pill bottles and go, okay, let's look at this. And you're doing a med reconciliation until you kind of find those things. And it seems so simple, yet it's not, right?
It's not. You're exactly right. And, I think over the years, by having a pharmacist on the team, the paramedics that I work with have realized, like, this is a lot more complicated than we at first were anticipating, right? And our Chief Crutchfield in Manatee County, you know, is probably a little bit ahead of the curve in recognizing that there's a lot of these meds that, you know, my team doesn't know, and I can reduce liability for my team and increase efficiency, not only that, but also accuracy for completing that med rec, right? And I would say that I do spend a fair amount of time, you know, playing a little bit of detective, right? What does the primary care have prescribed? What does the cardiologist have prescribed? And what did they get prescribed when they just got discharged from the hospital last week? And how do we, it's really like a double, triple, quadruple med rec from that standpoint, right? You know, plus they've got 5 medicines in their nightstand that they're taking and over the counter and
forgot about and didn't tell anybody. Yeah, I mean, I think this is such a fascinating topic. I want to switch gears a little bit because Emergent Leadership is about leadership, right? So I want to dive into, obviously this is a new program when you came on, right?
Yeah, so we got funded through a grant through the Department of Health in 2015. We actually started with operations in 2016, and really, so I've been with the team since 2016.
Sure. So you are still a faculty member. You're a professor, and so you're teaching. Obviously, you've got a passion for teaching. You've got a passion for learning. How does that translate in the EMS environment when you're trying to teach, and I'm going to use the word coach, and guide people into that thought process of it's not that easy and it is challenging? How do you navigate that from a leadership perspective when you get that pushback and people go, we don't need that, or we've never done that, or it can't be that complicated? How do you navigate that?
So, you know, I think that we only know what we know, right? And so even my paramedics were like, okay, so what are you going to do? You're going to shadow us, right? Like way back in the day, right? And you know, it wasn't until you go into a patient's house and you're like, so actually we can fix A, B, and C here, right? And the paramedics and the pharmacist can work together to solve a problem. And the paramedics realize like, oh, I see. Okay, so that takes this whole chunk of responsibility and like tasks of things that I have to like connect with the primary care and try to, you know, communicate A, B, and C needs or side effects or whatever off of my plate. And vice versa, I get to learn all the time from my paramedics, right? So there's their expertise in so many different things compared to what my training history is. And so I think that, you know, until you really explore that partnership and see how much more effective you are once you're working together, that it's difficult to demonstrate that. But I feel like ultimately the results of our program speak a lot, you know, for themselves. So I would say that's answering the one part of your question about how do we translate well, do we really need this expertise or not, right? So that's the one piece of it. The other thing that you mentioned was that, you know, I teach, I have this love for teaching, I have this love for learning, and how does that translate into EMS? And one thing that I've seen over the last several years is that, you know, paramedics, I love this spirit. You guys realize, you know, really what the needs in our community are and that you can meet that need. But at the same time, you're walking into a house, there's 4 different vials of insulin, and you're like, I don't know, his sugar is like, you know, less than 200. That's pretty good, right? And so you're kind of flying a little bit without all of the tools that you need to really feel confident in your job and being able to execute preventing that next emergency to the best of your ability. So the education piece is like a huge passion of mine for EMS.
That's so great. So I'm hearing you saying that your style of leadership is to dive into the trenches and to be in it, and that respecting people who know things that you don't know, even if, you know, you say, okay, I've got a PhD and I spent 8 years learning these things. There's something I don't know that you do, and that partnership and that team is stronger because of all the pieces on the team. That's what Absolutely. I just heard you share in a story. people say that all the time, right? Like, I don't know the quote because I never know the quote. Like every episode, I'm like, what was that thing? But it's the sum is bigger than the equal parts. You know what?
Yeah.
Yeah.
No, of course, right now, we both have thought of it if we weren't asking.
Yeah.
But yeah, no, I think, and probably everybody listening knows exactly what you're talking about, right? Yeah. The sum of everything together is greater than all its parts, or something like that.
Yeah.
And so, but that's the basis of team-based service in EMS as well. So I think everybody knows what we're referring to here. And I would agree with you. I do have a tendency to dive in. I've always been a service-based leader, right? My very first leadership role ever, like way back in college, was like, well, nobody wants to be treasurer. And I'm like, well, I guess I'll do it if nobody's going to do it. Yep. And so I've always been somebody that is like, well, there's a need here, and I feel like I have the skills that I can do it. So let me try to help, right? And I've taken that service-based leadership, and I have realized that a lot of my own personal passion lies in that, right? And we have this underserved population that needs us, and that there's a model of community paramedicine, mobile integrated health, that has had a huge impact in reducing the healthcare costs and improving the outcomes of that population. And so there's a need here nationwide, and I just feel like I'm ready to step into it. I'm ready to take on that responsibility and help EMS as much as I can. It's definitely my passion.
Well, it sounds like you just have as much heart as everybody in this industry who you just described. So I think you're in the right place. And so, I think one of the questions that everybody wants to know, and the main pushback when we talk about mobile healthcare programs, is, well, who's paying for it and how is it funded? I don't want to talk about that, but I do want to know if there's something that you're advocating for, recognizing there's a need, you're in a successful program, if there's a thing we all should be doing to be able to push this spirit forward of truly meeting the needs of the community and filling a gap, what's the thing we should be doing as an industry that you've seen to push us forward and closer to that space where we can?
Yeah, so I think obviously the biggest challenge for most programs is the funding piece, right? And being able to demonstrate their impact so significantly that people are just ready to throw money at them to say, yes, we need it right now, right? So it's a little bit twofold. I do believe that some of the paramedicine programs struggle a little bit in figuring out how to best track outcomes, compile data on those outcomes, do solid, statistical analyses and evidence-based research on how we need to present those outcomes and what payers care about those outcomes, right? And so how do we connect all of those pieces so that even the really small paramedicine teams can demonstrate the value that they are having, right? And that we can launch mobile integrated health and community paramedicine into the value-based payment services arena. Right. So I know we have a lot of work to do, but I do feel that it's completely possible, and it's just going to take more completely open-minded, innovative leaders to jump in and say, no, like, let's try this completely new model and collaborate with physician groups, collaborate with payers to implement that.
No, that's great. And you're right. Nothing's impossible. I think it's so difficult, and we get so bogged down sometimes in why we can't do something. We don't realize how possible it is. Because when you get a few people that have that level of passion and that drive, interest, especially when you find someone like you, someone like this fire chief that you're working with, or the EMS chief, I'm sorry, that are willing to do the work to prove concept, because that's really, I think, where that still is all these years later. There's still a lot of concept proving that I'm hearing you say needs to be done. One of the things that I know, at least I'll speak to, global medical response has kind of transitioned to a lot of kind of nurse navigation and nurse triage, and there's a lot more, of course, because of COVID, support for telemedicine and telehealth solutions. So I think our industry is in a space where things are changing, whether we wanted them to or not.
Yeah.
And I'm curious to know, like I said, my interest is, where do you think that there's a space for this in the future? And is there maybe an opportunity, or maybe you're already doing some virtual support with this program? Do you guys do anything virtually, community kind of telemedicine, telehealth stuff?
So we are in the process right now of navigating the telehealth piece. 2020, of course, has been a whirlwind, right? In pivoting and balancing the EMS demand for COVID versus paramedicine. So I would say that, ultimately in like big visionary long-term, I can see EMS teams, mobile integrated health teams, community paramedicine teams being the extension of chronic care management that is necessary, right? And so there are models throughout the country already that have piloted, partnerships with like primary care offices, for example. Okay, so you have, or if you have a nurse practitioner on your paramedicine team. So that nurse practitioner can bill for chronic care management, for transitions of care management, for chronic care management, for remote patient monitoring. These are all sources of revenue, right? But a nurse practitioner can't manage every single one of the patients, right? And so, so from my standpoint, that is one area where, for example, we could explore, right? Because as a pharmacist, I have the education level and the experience with chronic disease management that can help support the paramedics for widening the scope of that nurse practitioner or that physician to execute via telehealth or in person the chronic care management piece, for example. Right? So the nurse practitioner or the physician is the provider, but the pharmacist could execute those services on a chronic disease management piece, and that's a revenue source now, right? Or you could contract with groups for so many dollars per patient, right? And the paramedicine program with a pharmacist, with a nurse practitioner, with a social worker, an interprofessional team manages the chronic disease elements on behalf of that physician, and the physician's group earns dollars of revenue from the services that the program provides, right? So I feel like it's a little bit limitless. Like, let's just figure out what works for that physician group and that community, and for that payer, and you can come up with a solution.
Right. And I think you're right. It's about, the thing that we used to talk about a lot, except when I was a little bit more in the thick of this, was if you try to do, this is sales, right? If you try to do what works for that person, the way you sell it is going to look and feel different, and the way that it's received is going to look and feel different. And so sometimes for those listening who, hopefully I didn't shut it off at the first thought of it, and they're like, okay, I'm listening still, but I'm doubtful, or I don't understand it. Or those who have never really thought about this and think, hey, maybe there's a new opportunity. How do they continue the conversation, and how might you be able to support them if they want to explore what it might look like in their community?
Yeah,
or can you?
I think most teams may not be there yet, right? So we're still in the phase where a lot of them are figuring out what to track, how to demonstrate what they're tracking and what their outcomes are, in figuring out who to present that information to, right? And so I think that is the first piece of it, is making sure that from a documentation standpoint, a data tracking standpoint, that they have the data necessary to demonstrate the value. And then, there needs to be some research done on, okay, so who gets compensated for that value, right? So if we have physician structures through like MIPS and MACRA legislation where physicians, their CMS reimbursement is being impacted by, patient outcomes. Well, if I can change that for you, what does that look like? And how can we partner? So it just depends on where each program is, right? As you can tell, I could probably launch in and talk about these things forever. So anybody can, of course, contact me at any time, and I will always, share my thoughts and see what I can what I can do to kind of help people gauge where they're at and what some opportunities are for them that they haven't yet explored. But yeah, I think we're not quite at the sales piece yet for most teams. I think we're still a little bit in figuring out, okay, so from a chronic disease, outcomes-based results, where are we? And are we tracking that data to be able to demonstrate it?
Mm-hmm. Because that is, you can't sell it if you can't show its value, because otherwise it's just an idea. And I think a lot of people in the industry are sold on the idea. They don't know how to do that legwork piece, that dirty work piece, or the data piece. And that's where a lot of programs struggle is, how do you really show a difference? I'll make the argument that there's a lot of that in a lot of different pieces of pre-hospital care that can't prove the difference in the outcome. And again, maybe a story for another day, but I think a lot of that is because of, again, that gap in communication, that breakdown in that interdepartmental or interorganizational or the different stakeholders in the healthcare continuum. But I am so fortunate that you spent some time with me today. I, of course, am glad to know you. If people want to continue the conversation with you, how do they do that specifically? How can they find you?
Yeah, so I can provide my email address. So my email address is my last name, first initial, reinhartzv@gmail.com. I do actually, because I'm a licensed consultant in Florida, I do have my own consulting company, so that you can find me there at mobilehealthconsultants.com if you'd like to reach out to me via website. And I'm sure, Brett, you'll have contact details and things available. I'm also on LinkedIn, of course, so anybody can feel free to reach out to me.
Perfect. Dr. Reinhartz, thank you so much for taking the time to talk with us today. Manatee County is fortunate to have you.
Oh, thanks. I enjoyed it so much. It's my passion, and once you get me going, I'll talk about it to anybody. So thanks so much for having me.